Welcome to this module on person-centered language and health equity. In this module, we will do the following. 1. Define health equity and fairness. 2. Explore the links between language, discrimination, and dementia. 3. Explore the importance of person-centered language in enhancing equitable care. What do we mean when we talk about health equity? Health equity means that everyone gets a fair opportunity to be as healthy as possible. Health equity requires the removal of obstacles to health. Let's think about the definition of health equity, which uses the wording, a fair opportunity. What does fair mean? Fairness does not mean making things equal or the same for everyone. In the top row of this image, everyone is asked to use the same bicycle regardless of their ability or size. In the bottom row, each person is given a unique bicycle that meets their needs. Using this analogy for healthcare means that providing the same care for all does not meet everyone's needs. One size does not fit all. The following factors can all affect a person's opportunity to be as healthy as possible: low income, bias and discrimination, low education level, housing insecurity, and difficulty accessing healthcare. These are referred to as social determinants of health and are an important part of health equity. So, you're probably thinking, most of these things are outside of my control as a healthcare provider. Is it really possible for me to contribute to fairness or equity for patients in my care? For point-of-care providers, bias and discrimination is an area that you can reflect on. What do we mean when we use the words bias and discrimination? Bias is a predisposition, prejudice, or generalization about a group of persons based on personal characteristics or stereotypes. It can be unconscious, which is known as implicit bias, or it can be conscious, which is known as explicit bias. Discrimination is an action or a decision that treats a person or a group badly for reasons such as their race, age, or ability. Let's explore this a bit further by looking at types of bias and discrimination against older adults and people with dementia. We will start with ageism and ableism, two forms of bias frequently encountered by persons with dementia, and then we'll explore explicit and implicit ways that bias is conveyed. The World Health Organization defines ageism as the stereotypes, how we think, prejudice, how we feel, and discrimination, how we act, towards others or oneself based on age. Ageism includes attitudes and beliefs towards older adults, as well as actions resulting from these attitudes and beliefs. The use of non-person-centered language strengthens ageist stereotypes and beliefs. On the right-hand side of this slide, you will see examples of ageist language. Think about how these might impact perceptions, interactions, and care choices for an older adult in your clinical setting. Ableism is similar to racism, sexism, and ageism in that it includes stereotypes, generalizations, and demeaning views and language about a person's physical or mental abilities. Ableism is discrimination against persons with a disability. It reflects the belief that persons with a disability are less worthy of respect, less able to contribute, and of less value. Let's look at some examples of ableist language on the right. In these examples, we see that persons with dementia are viewed as draining healthcare resources. Persons with a chronic condition or illness, such as depression or mental health concerns, are said to be sufferers, and therefore helpless, or they are identified by derogatory stereotypes instead of as persons. And the term atypical presentation in elderly infers that the younger adult is the norm and is the standard of comparison. A 2017 survey of Canadian attitudes towards dementia found that 51% of Canadians admitted to using derogatory or stigmatizing language about dementia, such as "she's losing her marbles," and 30% of Canadians admit to telling dementia-related jokes, such as "I can't remember, I must have dementia," or "he has Alzheimer's disease." These are examples of explicit bias, which means we are very aware of our prejudice and attitudes towards age, ability, and dementia, and we are purposely and consciously using language that is hurtful and inappropriate. What does implicit bias and dementia look like? Implicit bias is attitudes or prejudices that we hold about others that we are not conscious of. This can result in our unintentional use of language that is hurtful and inappropriate. Language that stigmatizes, dehumanizes, labels, or infantilizes creates a narrative that the person with dementia is less valuable, less of a person, or less able. This hinders attempts to form a therapeutic relationship with the person and undermines attempts to determine causes of responsive behaviors. This, in turn, impacts care choices and provision of care. Persons with dementia may be seen as being beyond help, doing this on purpose for attention, or less worthy. These narratives prevent thoughtful evaluation of responsive behaviors and generate negative perceptions of the person, such as they are uncooperative, resistant to care, or intentionally disruptive. Our biases influence our language and actions. The words we choose can support or hinder the ability of our patients to receive equitable care. Ageism may lead to poor communication between healthcare providers and older adults. Healthcare providers may be impatient, dismissive, and less attentive to the healthcare needs of older adults. Condescending or infantilizing language may be used when speaking with older adults. The implicit bias of ableism can be harmful for the therapeutic relationship and negatively impact health equity. Persons with dementia face a double stigma of ageist and ableist bias. Dementia is not a normal part of aging, but the chances of developing dementia increase as we age, with older age being a significant risk factor. The ableist stigma of dementia is that of loss of status, loss of personhood, and that persons with dementia are less than others. This double stigma impacts health equity for persons with dementia. Biased language can create narratives that affect a person's access to home care or long-term care. Listen to this quote from a clinical team lead from a hospital discharge planning team.
What is really important is for the documentation to reflect the what and the why and the intervention and the outcome when responsive behaviors are encountered. The words aggressive or exit-seeking are used in the patient's chart without additional comments about what might have been happening at the time, like needing the toilet or other needs. Failure to have fulsome documentation leads to home and community care, and in turn, long-term care facilities drawing inaccurate conclusions because they have limited objective data.
How can we change the narratives about dementia? Here are 3 ways. First, be kind to yourself and others around you. Listen to the language used and think about what is said and written. Implicit bias is normal. We all have implicit biases. Reflect on your own biases and the potential impact they may have for patients and colleagues. Take steps to broaden your viewpoint and learn about person-centered language. Second, use person-centered language to describe responsive behaviors. The way we describe responsive behaviors influences our efforts to find the meaning or the cause of the behavior. The words we use in a patient's chart can create filters through which the next clinician or team views a patient. Non-person-centered language choices generate negative perceptions of the abilities or behaviors of the person with dementia, contributing to discrimination and health inequity. And third, see the person first, not their diagnosis. Be mindful of times when you might be viewing the patient by their diagnosis, rather than by who they are, and take steps to change this. You might be wondering about responsive behaviors and using person-centered language. How does person-centered language make a difference? A key principle of dementia care is that all behavior has meaning. When we use person-centered language, we provide clear and unbiased descriptions of behaviors. This can promote evaluation of possible meanings and causes, helping us to provide dementia care that meets the unique needs of the individual. Person-centered language is specific. This means writing a brief description with precise details on the who, what, where, and when something has happened. Using specific language allows other team members to easily understand what you are describing with less room for misinterpretation. Specific language enhances our ability to plan and evaluate patient care. It enables the team to implement interventions and evaluate their effectiveness through the use of clear details that are not open to misinterpretation. Person-centered language is objective. When we use objective language to describe our assessment findings, we use observable or verifiable facts and not personal opinions. What we write will influence the next clinician who interacts with this patient. The words used in a patient's chart can follow them throughout their stay in hospital and can influence the discharge planning process and access to long-term care. Person-centered language is respectful. This means using language that avoids labeling or infantilizing the patient. The language we use can promote, empower, and increase self-esteem, or it can demean, devalue, and disrespect those it refers to. Through our language, we can demonstrate a recognition of identity, personhood, and respect. Using specific and respectful words when we communicate with older adults means our conversations don't condescend or infantilize. One strategy to combat ableism and ageism is to use language that puts the person first. This helps us to see them as a person rather than only their diagnosis, and helps to reduce the potential for stigmatization and discrimination. Identifying the person first and their condition second helps us see the person first and not their diagnosis. A person's condition does not define their identity. So instead of demented patient or dementia victim, we would say person with dementia. Instead of substance abuser, drug addict, or drug seeker, we would say person with a substance use disorder. Instead of suffering from depression, we would say person with depression. It should be noted that not all persons with a disability prefer a person-first approach to language. When in doubt, it is advisable to ask the person what words they would prefer to be used to introduce or describe them. When we use person-centered language, we see the person rather than the disease or symptom. We break the chain of negative narratives and biases. We provide care that is person-centered and inclusive, responding to the unique needs of each patient. And we promote health equity for persons with dementia.